Thank you, Luisa. It is my big pleasure to be here with you. I'm sorry for the long introduction. It was very nice, but a little bit long. I'm happy to be here talking about this very dear area of my working days, every days with cancer patients, and to talk about their suffering from a disease, in this case, pancreatic cancer, which is still in this time very dreadful and very disturbing for our patients. So I'm going, and thank you, Gabriele, for making the point of a son of someone who has endured cancer, because families also are part of this nucleus of issues, psychological and emotional issues. I will be trying to um, share my screen. Hopefully this works. Give me a little bit of, let's see if it works. Is it working or not? Are you seeing this?
Almost there, Lucia. We still have the black screen. Now it works. Go ahead. Thank you.
Okay, so it is, I congratulate and greet the Pancreatic Cancer Europe to have addressed this issue, which is always a little bit on the silence and mode and neglected, because patients usually have more difficulty in disclosing that they are suffering. They feel somehow it's not the purpose to disclose that. And most of the time, healthcare professionals also do not ask these questions. So let's see how can we improve our care to patients. First, it is very important to know that although this disease is very problematic, and in this case, it brings a scenario of dreadful scenario, mostly the patient emotional reaction reacts to the way they perceive their disease as well as their resources. But because cancer has a very bad reputation, the emotion that it arises from the patient brings them all the past experiences related to cancer and what they have heard in the media about it. So we need to perceive that all of a sudden, with the diagnosis, this also opens up their demons boxes, their Pandora box about all the things that they have feared or have heard about what is cancer. Also, cancer impacts on a multi-dimensional level. It's not only the physical level by the pains and the fatigue that the cancer and the treatment brings to the patient, along with the treatment in dysfunctionalities and the impacts on sexual life, but also they are being filled with emotions that in many cases they have not felt before. Very strong emotions of sadness, of despair, worries, loss of autonomy and control, things that they are not usually um, uh, related with or have experience with. Because this is a very frightening situation. They don't know anything about cancer usually, and what they know is not helpful. And so it disrupts their life. Also, their roles, family and social interpersonal roles, it puts pressure on financial strains. And also, probably it's the first time that they realize their mortality and have to confront with issues of what's going to happen. And also, they have to deal with strangers, which is us, healthcare professionals, which they have to uh, build trust, and we have to be part of the solution. We have to facilitate this relationship by using good communication skills to help facilitate this coping process of understanding a disease that they don't know about, understanding what are my hopes, what are the solutions, what can I hope for, what is my role, how can I support and help all the process. So it is very much up to us, the healthcare professionals, to guide the patient into the right direction, to keep them hopeful and engaged into treatment. And for that, we have to have a lot of empathy, respect, listening, and trying to understand who is the person in front of us. What do they want? What is their concerns? What do they expect? What are their aims? Because this is brings an array of demons, as I call them, fears and alterations in patients' lives, they suffer emotionally. And this has been described as distress to destigmatize it from the psychopathological nomenclature because they don't have they don't have a psychopathological problem. They have just an emotional reaction related to the cancer diagnosis and to these crises of having to endure all of these changes and not knowing in many cases what to expect. And so while some patients deal well um, or less badly with the situation and they adjust, others will not adjust so well and will tend to develop situations of anxiety and depression, which will impair all the process of treatment and ultimately clinical outcomes. Pancreatic cancer has prevalence of around 37% of patients that have this severe type of stress that requires emotional specialized support from psychologists specialized in psycho-oncology. And we know that pancreatic cancer has a high mortality, poor prognosis, and while there has been some progress, the 5-year and 10-year survival rates are still low, and there is a high burden of cancer-related symptoms, pain and digestive problems, and also emotional ones, and depression, anxiety that interfere with sleep. There is excessive worry and ruminative thoughts, difficult concentrating, and sometimes maladaptive behaviors such as increased use of alcohol and other drugs, social withdrawal, and somatic complaints. Depression and anxiety affect the quality of life, the motivation to engage in treatment, cancer clinical outcomes, and even become a major cause of death because patients are more prone to suicidal ideation, which we have to capture. Also, this depression, this emotional disturbance not only affects the patient, but also the family. And the studies show that indeed pancreatic cancer is one of the highest with emotional alterations, either depression, anxiety, or mixed anxiety and depression. Uh, the problem is, besides impairing quality of life, is that if we don't address this depression, it impairs clinical outcomes, as I was mentioned, not only by impairing quality of life, but it reduces compliance with treatment, less efficacy of chemotherapy. The patient becomes more psychosomatic, so shorter survival expectancy, longer hospital stays, increased cost, burden for the family, and as I mentioned, higher risk of suicide. Studies have shown with other populations that if we react like this with a maladjustive coping attitude, like these patients, breast cancer patients with a hopelessness attitude, 10 years of studying follow-up shows that they survive less than patients who have reacted more adjustedly. This goes on for other cancers, and that we have verified that depression, for instance, is a predictor of mortality among cancer patients after stem cell transplantation, as you can see here in this graph. So here we have a lot of nowadays scientific studies which show this relationship of depression with the poor clinical outcomes, which brings the notion that psychosocial care is important in the treatment of patients. It's not a luxury, but indeed an essential requirement for the treatment of cancer patients. In this study with many patients, almost 24,000, they found out that almost 8% of patients had the diagnosis of depression. A diagnosis of depression is already the extreme of the distress. You've seen that 37% of patients have severe distress, which 8% can be severe depression, okay? And this depression is linked in local regional disease with 37% lower odds of undergoing surgical resection. And the depression was associated with a lower 2-year survival. And for patients who underwent surgical resection, depression was a significant predictor of survival. Patients with distant disease, sorry, these are the graphs, did also had lower odds of receiving chemotherapy. So we see that depression really impairs the possibilities of patients have better outcomes. So the recommendation is that we should recognize this emotional suffering in patients and improve the treatment so that they have access to better clinical outcomes. These are the curves of what I've just shown you in survival of 2 years of pancreatic cancer patients, and the ones who have depression always have worse results. So there are some theories and explanations about why this happen, and most of the studies have shown on biobehavioral studies linked with the negative emotions that there are inflammatory processes, biochemical, immunology, and hormonal processes that can explain why they have poor outcomes. But they also have poor outcomes because they don't understand, in many cases, what's going on. They catastrophize the situation, and they don't see a light at the end of the tunnel, and they don't enjoy the journey of their own life and their quality of life that they can have. The good news is that we have uh, interventions at the psycho-oncological level that have proven its efficacy and efficiency in reducing anxiety. I bring here this table showing different interventions which have been proven level 1 and 2 evidence for reducing anxiety, and the same for depression. So we have various tools that do improve and reduce this distress, allowing patients a better opportunity for survival, like this randomized controlled trial of cognitive behavioral stress management for breast cancer patients, with show that patients who have undergone intervention for reducing their emotional distress have better survival outcomes than the ones that did not. Other techniques used also to that show a large to moderate effect on the mental health of breast cancer patients. And I would like to end up my introduction by addressing this European Cancer Organization essential requirements for quality cancer care for pancreatic cancer patients, which already recognizes that while there is the core multidisciplinary team to treat the disease, there is the extension, the importance of the extended multidisciplinary team to support all that is going on at the personal level. And psycho-oncologists should be part of the treatment multidisciplinary team. and that this care should be provided. That's what the recommendations state, must be provided at all stages of the disease and its treatment, for family patients and families, and be present to ensure comprehensive cancer care. The distress thermometer, which is a tool similar to the pain thermometer to assess distress in patients, which can give us an idea of the level of suffering, most likely, or most in parallel, like the pain assessment, to give us an idea of how severe is this distress for the patient, so that we can make a referral for specialized psychosocial care for the patients who need it. And that psychosocial interventions do follow clinical practice guidelines. So to close, I would like to give you here a phrase from my good friend who is director of the psycho-oncology department at the Memorial Sloan Kettering Cancer Center in New York, that he says, when you have pancreatic cancer, convening a support team to address all of your needs is the key first step to success. Unfortunately, it's not uncommon for patients and caregivers to focus their efforts on the physical cancer at the expense of addressing the whole person. But bolstering patients' mental health is just as critical. As we have seen, it helps to optimize clinical outcomes, including survival and, of course, quality of life. So I would end by saying no one with cancer should be left alone with their demons, their fears, their uncertainties. They should be helped to have tools to address this common enemy, their own exaggerated fears, and to help them to live their own life as best as possible. Although we know the journey has many challenges, but nevertheless, if we have a good support system, the patient is more likely to still enjoy his life, even if it's still enduring treatment in many cases. So I thank you. I have the fortunate to be working at the Champalimaud Foundation, which has recently opened up the Boston Champalimaud Pancreatic Cancer Center, which is this one here, linked with the initial foundation, which we address all the types of cancer, adult cancers. But this is a whole building only dedicating to this area of pancreatic cancer, because it has been one in the last decades that have not seen much progress in terms of survival. And so we want also to be part of the international community that supports patients and finds solutions to improve their outcomes. So thank you very much for having me and for addressing this issue, and hopefully that will help uh, all the hospitals and countries to place more attention in the pancreatic cancer patients' needs while in treatment and afterwards. Thank you.